for evaluation of patients awaiting non-cardiac surgery. Nearly 50% patients that are referred to our echocardiography department in our hospital are those awaiting clearance before the surgery. Although useful and informative, one must realize that risk stratification before non-cardiac surgery cannot be done on the basis of echo alone. Several factors are to be considered when assessing cardiac risk. Patient-related factors like age of the patient, the medical history, the functional status, surgery-related factors like the type of surgery, the urgency status, the surgical duration, and test-related factors like the sensitivity and the specificity of the test and its effect on management. Clinical predictors of increased perioperative cardiovascular risk include the major, intermediate, and minor factors. The patients of unstable coronary syndrome, decompensated heart failure, significant arrhythmia, and with severe valvular disease are the major predictors. And the patients of mild angina with compensated or prior heart failure or renal insufficiency or with diabetes are in the intermediate group, while advanced stage of the patient, some abnormal changes in the ECG like atrial fibrillation, STT abnormality, LBBB, etc. fall in the minor clinical predictors. The surgical risk estimation according to the type of surgery or intervention is very important. In this regard, it has been seen that the high-risk surgeries carry more than 5% risk of cardiovascular events, whereas the medium surgical risk is between 1 to 5%, and the low surgical risk is about less than 1%. So patients who are undergoing surgeries like adrenal resection, aortic and major vascular surgeries, pulmonary or liver transplant fall in the high surgical risk group. So timing of surgery is also equally important. In general, acute procedures carry a higher risk of complication than the elective procedures. Uniform timing definitions are unfeasible as the time spans may vary between disease. These guidelines use the timing definition as if surgery or intervention is needed immediately or urgently, or whether it is a time-sensitive surgery. For example, the cancer surgery or the carotid surgery to prevent stroke in symptomatic patients are typically time-sensitive surgeries, where the time window for time-sensitive surgery will vary depending on the underlying disease. And the elective surgery can be performed electively without any significant risk of losing a limb or organ function, and it has less risk of complications. Many factors affect outcome when comparing acute or time-sensitive versus the elective surgery. However, when the best interest of the patient should be considered before deciding on treatment. So active cardiac conditions that are contraindication for non-cardiac surgery include the unstable coronary syndromes, patients of unstable severe angina or recent MI, patient with decompensated heart failure, NYHA functional class 4, patients with significant brady or tachyarrhythmias, and patients of severe valvular disease like severe aortic stenosis with a mean pressure gradient more than 40 or valve area less than 1, and symptomatic mitral stenosis patient with progressive dyspnea on exertion or exertional presyncope. The EAC 2022 has set a guideline for recommendation for trans-thoracic echocardiography. So in this guideline, class 1B and class 2AB patients are recommended for a trans-thoracic echo while they are undergoing high-risk non-cardiac surgeries, and these patients have a high NT-proBNP level or a murmur or a low PO functional capacity. However, the patients belonging to class 3 level C, this is not a routine preoperative evaluation. In these patients, a routine preoperative evaluation with trans-thoracic echo is not recommended.